Okay, let's start by introducing our first speaker. Dr. Keith Dawson is an emeritus professor of medicine at UBC and an endocrinologist at the Vancouver General Hospital. He has been a major participant in the Canadian Diabetes Association guidelines for the prevention and management of diabetes for 1998, 2003, and 2008, and he was a reviewer for the 2013 edition. Dr. Dawson has been an investigator on many research trials in diabetes care. He has been director of several diabetes clinics in Vancouver at the Shaughnessy and Vancouver General Hospitals and has treated patients for over 40 years. He has been active in First Nations work, participating over many years in diabetes education and treatment through the First Nations Mobile Diabetes Telemedicine Clinic and in diabetes education, including all treatment options and goal, as provided in 8 languages on the web www.livewellwithdiabetes.com. He is a recipient of the Community Leader Award from the Prime Minister's Volunteer Awards in 2014. Dr. Dawson will be presenting on the topic of diabetes care in Indigenous people. Dr. Dawson?
Well, thank you very much for that kind introduction, Kathy. As from that introduction, you can see that this is a vast subject, and obviously we can't review the entire field of diabetes care and all its relationships with First Nations peoples. But we're going to touch on some highlights of them, identify what the Diabetes Canada has done in this sphere, and I would like to put right away a major plug in for the excellence of the Diabetes Canada guidelines for 2018 now. They really are excellent. I have to admit that I have been the recipient of grants and awards from multiple pharmaceutical and other industry sources, and obviously we have to be concerned about bias that might ensue from that. But I have to emphasize that any potential bias from items identified in the previous slide have been mitigated to the best of my ability by the full recognition of the potential of that bias and by a conscious effort to avoid it and even to provide contrary views. Now, helping First Nations in the delivery of health care relates very importantly to some unique features which most of us in Saskatchewan are aware of. First of all, the historical and cultural factors in Indigenous and First Nation health care has to be emphasized. The learning outcomes we're going to deal with some of the medical aspects as well as just the psychosocial and cultural ones, to understand the therapeutic options in individualizing anti-hyperglycemic therapy for people with type 2 diabetes. We have a multiple array of medication now which has changed in the last 4 or 5 years dramatically our approach to treating people with diabetes, whether they're First Nation people or other citizens. And we have to understand that we now have sulfonylureas as well as metformin, and also sulfonylureas, the DPP-4 or incretin group, SGLT2 group, glitazones, injectable therapies is a vast thing. We formerly had just insulin. Now we have GLP-1 and insulin, and GLP-1 and insulin combinations. So we have to understand how to approach your patient, how to generate motivation, and place the patient in the driver's seat. If I was to summarize the most important thing I've learned in the last 10 years is our inability to really motivate and allow people to continue to treat themselves. They have to take responsibility. Treatment of this disease is not just a treatment of a disease as we do in most medical fields, but wellness includes total mental and spiritual health. This is hard for many Western physicians and healthcare deliverers to understand that if a person isn't happy or satisfied with themselves or their society, they're not going to adopt readily any change in behavior. If they are depressed, if there's economic hardship is present, it's hard to have spiritual health. And spiritual health is a very important facet, particularly in First Nation people. Healers in the First Nation population have achieved a significant role, and they are respected correctly by First Nation peoples. But for us to disrespect them in any way as healthcare deliverers is a sad mistake. It is striking how the importance of some of the advice from First Nation healers has to play in the delivery of care, if only from the point of view of understanding the placebo effect, which is terrific. If you think something's going to help you, it does help you. If you don't think it's going to help you, it doesn't help you. That's an important concept. The pervasive effect of residential schools has also been brought to me, home to me. I've worked with Chief Bobby Joseph in the delivery of our health care in First Nation groups. The fact of residential schools, let me give you a tiny example. If I were a First Nation pupil and somebody came to me and said, oh, I want you to do this, this, and this. I said, the last time you gave me advice, you said I have to be taken out of my home, taken out of my family, and go live in a faraway place, attend a residential school, and stay there, and abandon your language, abandon your family, abandon all your historical and cultural background. But this is really good advice. Now I'm coming at you with more advice. You go, thanks a lot. Your past track record is not impressive. So the pervasive effects of colonization and racial intolerance in society is a really significant problem. The current situation, First Nation diabetes situation, is unbelievable. The prevalence of type 2 diabetes rate in Indigenous adults above 35 years of age is about 50%. The lifetime risk, if you're a male at the age of 20, you have a 75% chance of getting diabetes before you exit this earth. If you're a female, 87% chance. It's predicted that 8 of 10 indigenous people in their 20s will develop diabetes at some point in their lifetime. For the non-Aboriginal population, 5 of 10 non-Aboriginals will develop diabetes. So we're dealing with, and this is a published paper from Alberta actually, and we are dealing with a major problem. So some of the medical aspects of diabetes care in Canada, we have now a classification of diabetes, and this is produced by the new guidelines. And I think all of you are familiar with that. Basically, we've all understood that we have type 1 diabetes, which is a pancreatic beta cell failure, usually in onset in a younger age, and producing insulin deficiency, and is autoimmune mediated. That is, the patients have antibodies to their own insulin-producing cells. There's another form of that, the LADA, or the latent autoimmune diabetes in adults, which is very similar to type 1 diabetes, but occurring later on in life and is also confusing for healthcare delivery people. And then, of course, we have type 2. And remember, in our country, type 2 diabetes is about 90% of the population. We have gestational diabetes, which frankly, you'll be hearing more about that in the subsequent lectures today. But gestational diabetes is really a type 2 diabetes that's been put into the fore early because of the pregnancy and the hormones of pregnancy. And the treatment is different. And then we, of course, very rare autoimmune other types. But let's look at another classification, or another way of looking at it. What are the clinical features? Type 1 diabetes is usually before the age of 25, usually a thin person. They have usually islet autoantibodies. Their C-peptide, that portion of the insulin molecule that's broken off when insulin is secreted, and is an indication of how much insulin a pancreas of an individual is producing. That's usually undetectably low because they do not produce it. Insulin production is usually absent. First-line treatment is insulin, and we all understand that. Type 2 diabetes is really quite different, but it has changed. We all know it used to be greater than 24 years of age and higher incidence as we get older. But the incidences have been increasing in adolescence, and this is directly, unfortunately, directly correlated with obesity in the youth population. At least 90% are overweight, if not obese. Islet antibodies are not present in that form of type 2 diabetes. C-peptide is normal, high. In other words, if you measure how much insulin is this person secreting, they're secreting more insulin than the normal person, than the other person. They are making more, but it is ineffective. And non-insulin anti-hyperglycemic agents are the first-line treatment as opposed to insulin. The frequency is of family history, very high, 75 to 90% of people with type 2 have at some point in their life got a relative who has diabetes. And diabetes ketoacidosis is rare. So there are monogenic forms of diabetes which they're so rare that we really don't need to discuss them in this short interval. The clinical approach to classifying diabetes is a new publication from Sweden very recently, in March of this year. And it's a very interesting publication. They took thousands of patients in Sweden, and they looked at them in a retrospective scope. What were they presenting as? How did they evolve? What were their treatments? And how were the complications? Did they differ in different types of diabetes? And that is really fascinating. For example, they've put clusters. There's 5 clusters. I predict that we will be treating people based on this type of an assessment rather than our historic one of, oh, you're type 2, you're type 1, or you're gestational. We'll be treating them this way. Well, about 6.4% of cluster 1 are those that have what we call type 1 diabetes or LADA, relatively low BMI, poor metabolic control, insulin deficiency, and glutamic acid decarboxylase antibody positive. That's only 6.4% of the population. About 17% are actually very similar. They're similar, but they're glutamic acid decarboxylase GADA negative. These people are very different than the others. They have the highest incidence of retinopathy. And so if you identify that sort of a person in your practice and you're going to start treating, be aware of the importance of having an ophthalmological assessment. These are considered as severe insulin deficient diabetes, as identified on the right of the screen. Then about 15% have insulin resistance. Now we're getting into the more classical type 2. High BMI, high body weight, highest incidence of nephropathy. And that's really quite striking. The Cree population, for example, has a very high incidence of nephropathy compared to other First Nation populations in Canada. They exhibit severe insulin resistance. When you've got a patient like that, you recognize, oh, we're going to have to give 100 units or 150 units of insulin just to control them. And remember, they have high levels of their own insulin being produced, but it's not effective. That's about 15% of the population. 21% of the diabetes population are obesity, younger age, not insulin resistant. And that's mild obesity-related diabetes. That is 21% of the population. And then the largest group, almost 40%, are older age, modest metabolic alterations, mild age-related diabetes, as shown on the right. These differences become clinically important because if we're treating somebody with severe insulin resistance, I would go all out not to start insulin in a patient like that. Use the various new oral agents which are dramatically effective. If, on the other hand, you have a person who's insulin sensitive, you have to be aware, oh my gosh, starting insulin in a patient like that is a dangerous act. We have to be very careful, make sure they understand if they're taking insulin, that they're sensitive to it and will have hypoglycemic reactions much more. Now, diabetes self-management education is the greatest defect in current care for our diabetes patients. It's the motivation to self-management. I personally recommend diabetes self-management into almost all patients with diabetes, it's written. But I believe it's especially important for you. This is what you need to say to a person. I recommend it's especially important to you because you have many decisions and choices. You have to make those decisions and choices every day that affect your diabetes and health. The more you know, the more wisely you can choose. Many people tell me that talking with others who have diabetes helps, and that is really true. If you approach diabetes care in a group fashion or a circle of people with diabetes, it is very informative and it gets pervades the pervasively good education. Many of my patients tell me, oh, they don't want to go back to a class. I went to that class. But after they come back from the class, they always have thanked the healthcare deliverer. Thank you for having sent me to that. That was really good. You, the patient, are the most important person in managing your diabetes. I'm here to give you advice, guidance, and support, but not to tell you what to do in the sense, you do this or else. We do have to inform patients what the or else's are, that the unfortunate fact is this is a serious disease with major consequences. But we don't tell them, you do what I say or else. It has no effectiveness. Managing diabetes is hard work, and the more you know, the easier it becomes. Helping First Nations in the delivery of health care, first of all, starts with lifestyle. Unfortunately, those of us who are physicians have dealt with the medical aspect far too much and too little on the lifestyle aspects. Lifestyle recommendations have to encompass what should be done and also what can be done, and considers multiple factors, including the availability of what resources you have. For example, do you have an exercise capability? Are you living as an Inuit in very northern frigid climates? No. Or are you living down where you have an exercise group you can attend with your peers? Historical perspectives are important, and cultural factors are really important. We don't pay much attention to that. We've been very poor. The avoidance of obesity. Now, one of the things I'd like to drill, that you see lots of, oh, don't emphasize weight. Don't talk to your patient all the time about weight, because they turn off. That is true, but the avoidance of obesity is a major objective with greater importance. We're now learning this in youth. We identify now that people aged 11 to 17, getting obese at that age is really dangerous. We've got to address that most of us are not addressing that. Nutrition and diet can have many successful approaches, but clearly carbohydrate restriction and techniques of delaying absorption of carbohydrate have recently been identified, and our new medications approach it from that point of view. So it is important. Now, there are many mechanisms for addressing this. There's Mediterranean diet, there's low glycemic index, low carbohydrate, ketogenic diet, even the Atkins and South Beach diets are successful variants of basically the same approach. Attempt some caloric restriction and attempt some carbohydrate restriction. And I'd like to deviate a little bit. I have a pet peeve here. There's little evidence to support low fat in the diet today. And the concept of healthy fats or unhealthy fats will be abandoned, I predict, in the very near future, with the exception of trans fats. Healthy eating. What are some of the new considerations? Well, it's clear that if overweight, that is a BMI greater than 25, or more commonly obese, a BMI greater than 30, a weight loss, you should tell such patients, of only 5 to 7% of their total body weight, not getting down to normal, not getting down to a healthy BMI of 23 or something, just losing 5 to 7% of your total body weight has greater beneficial effects than almost any medication we have. If severely obese, with what used to be called morbid obesity or severe obesity, this is even more important. So we have to reduce either all carbohydrates or at least reduce high glycemic index carbohydrates, which require faster insulin responses, although the total amount of insulin in a high glycemic or a low glycemic diet is going to be the same per gram of carbohydrate. The current CDA, or Diabetes Canada, approach is to reduce calories if overweight, select low glycemic index carbohydrates, avoid saturated fats, and increase leafy vegetables and Mediterranean-type foods. I have to in advance tell you I have a bias against those statements. The Mediterranean diet was just withdrawn. They had to withdraw the publication, not because it was wrong, but because of technical problems. The concept of avoiding saturated fats has now been proven not to be essential. It is not important. It has nothing to do with it. It does reduce LDL, but it doesn't reduce heart attacks. And I'll come to that again. The question is reduction of carbohydrates to either less than 45%. The Diabetes Canada recommends 45 to 60% carbohydrate intake. That's nowhere near a low carbohydrate. Understand it. They consider that a low carbohydrate, but it's not. The reduction of carbohydrates to either less than 45% reduces lipids better, or reduce to less than 30%, which you have to replace, therefore, with some lipids. You have to give them more fat, but you're reducing the carbohydrates, is more effective in weight reduction than is the reduction of the fat content. The current thinking is that fat and cholesterol are no longer the major risk factors. The PURE study, P-U-R-E, is a Canadian-oriented study, which is a vast study of patients who have severely obese and yet were treating themselves with different approaches, have identified some major differences in low-fat and low-carbohydrate diets. The next thing is physical activity, a gradual incremental variation in activity recommendations that takes into account the age of the person. You can't send a person who's 75 or 80 out to run a mile. The physical capabilities are extremely important, personal preferences, and what's available. Do you have a pool nearby in a community? Do you have a group hiking? Do you have a community of people who are ready to go do treadmill or hiking daily? We now know that physical activity produces its major benefit. This is a concept that many healthcare workers and certainly all patients have no idea. They think that when I go out and exercise, I'm going to burn my calories. That is not how you reduce weight or reduce glycemic in people who are obese. The exercise allows you to reduce insulin resistance. So the insulin you have in your circulation is then effective. You have to run, I think it's something like 5 miles to counteract, to burn off 2 peanuts. That's really hopeless. But you are training your muscles. So the question is weight loss the secret behind the remission type 2? Let me just give you 2 instances which are recent ones. One, an open-label cluster randomized trial, the DIRECT trial, from 49 primary care practices in England, randomly assigned the patients to provide either weight management program, that's the intervention, or best practices by guidelines, just that's the control group, the routine way or a weight management program. Individuals 20 to 65 with type 2 diabetes for a minimum of 6 years with a body mass index from 27 to 45, not receiving insulin, mind you, were given this study intervention. The withdrawal of all anti-diabetic and antihypertensive drugs, and this is an anantha to those of you who are dietitians. Total diet replacement with an 825 to 853 liquid diet supplement taken for 3 months. It sounds unbelievable that you can persuade people to do that, but it did work. The step food reintroduction subsequently was done. Stepped food reintroduction, regular, and structured support. This isn't to advocate this approach, it's to say, what happens if you really do approach a patient with a starvation type diet? Well, the weight loss, co-primary outcomes were weight loss of 15 kilograms or more, and remission of diabetes, that is hemoglobin A1C less than 6.5, after at least 2 months of all anti-diabetic medication from baseline to 12 months. And these outcomes were analyzed historically. The weight loss of 15 kilograms or more was seen in 24% of the intervention group, nobody in the control group. Our standard method, nobody can achieve that degree of weight reduction. Diabetes remission 46% complete diabetes remission in participants in the intervention group, 4% in the control group. Our normal ability by contemporary methods achieves about a 4% diabetes remission rate. There was no remission in any of the 76 participants who tried this program but gained weight. 7% had remission who maintained a 0 to 5 kilo weight loss. In other words, 0 to 5 kilograms in the average person is not enough. However, 34% of people with a 5 to 10 kilogram weight had remission, and 86% of patients, of 36 participants who lost 15 kilos or more and body weight fell by 10 in the individual, they had an 86% remission rate. Now, I'm not saying that we should do this, but I'm saying that the weight loss clearly has a major role to play in the overweight diabetic type 2 patient. The importance of weight loss in the direct trial, diabetes remission control, reveals the importance of this weight reduction in achieving remission, and a drastic reduction of caloric intake in recently diagnosed type 2 diabetic patients. Drastic caloric reduction to 825 to 853 calories per day. Intensive weight management with a counterweight program has followed up on that with a 15-kilo weight loss. And a controlled study, 46% of 146 patients in this study who lost at least 10 kilograms achieved remission. That's half of the patients, remission from diabetes. 74% of those in the weight managed group no longer needed anti-hyperglycemic agents, and that effect persisted for 12 months after the study. So it can persist. There was another study, a randomized control study of remission. Randomly is divided 83 patients with condition into 3 study groups. 2 of the groups received an intensive metabolic intervention where they were provided with a personalized exercise plan and a suggested meal plan with reduction of daily calorie intake by reduction, not 2, but by 500 to 750 calories per day. One group underwent this intervention for 8 weeks while the other was treated intensively for 16 weeks. In other words, do you need to be on basically a starvation diet or at least 500 to 750 calories less than you've been accustomed to having in order to obtain the changes? This study included meds, metformin, acarbose. These were patients who had typically already on a basal glargine or acarbose or metformin for 3 months, and then they all stopped, and they assessed remission after 3 months. At 8 weeks, 50% of the 8-week intervention group versus 3%, 3.6% of the controls achieved normal glycemia on therapy. At 16 weeks, these percentages were 70% in the 16-week group, and in our control group, treated in our ordinary fashion, 3.6%. 3 months after the intervention was completed, 11 of 27 individuals in the 16-week intervention group met hemoglobin A1C criteria for complete or partial remission, compared to 4 out of 28 in the control group. 3 months after finishing 8-week intervention, 6 of 28 individuals met the same criteria for in other words, the criteria are met much more if you can extend it from 8 to 16 weeks. Up to 40% of participants were able to stay in remission for complete or partial diabetes remission 3 months after stopping the medication. So these 2 articles do point out the fact that weight really makes a difference. The problem is how to get people to do a weight reduction except by one of these methods. Now, one of the interesting things in both these studies was that the fact that they had lost so much weight so pleased the individuals in the stringent reduction group that they voluntarily wanted to stay in the program and accept a reduction in caloric intake. Not the strict starvation reduction, but they were happy to stay on a diet. So it's not that abrupt weight loss is no good, it's evanescent, they go right back to, no, if you've achieved weight loss, they don't go back so much. So what about diet? This is still discussed. The PURE study, Salim Youssef at McMaster University has initiated this study. 140,000 patients in 17 different countries. The study is called the Prospective Urban-Rural Epidemiology Study. This study studies what happens to people in diabetes care worldwide. A high carbohydrate intake was associated with a higher risk of mortality, whereas total fat and individual types of fat were related to lower total mortality. Total fat and the types of fat were not associated with cardiovascular disease, not associated with myocardial infarction, or cardiovascular disease mortality, whereas saturated fat, believe it or not, had an inverse association with stroke. The more you took, the more saturated fat, the less chance of a stroke. These are dynamically different evidence than we've had in the past. Global dietary guidelines have to be reconsidered in the light of these massive studies. Now, Diabetes Canada guidelines in 2000, they identify that there's, and these slides are from the actual Diabetes Canada 2018 guidelines. And there's some points I'd like to make. The key changes are reinforcement of the important role that they have in the diabetes guide of a registered dietitian in diabetes management. I'd like to make a point here. There's no evidence that it's a registered dietitian. The key point is that they've said that. But we don't have other good dietitians. So there's a rationale for saying, let's stick with registered, but they have emphasized registered dietitians, which I feel is an important mistake. The importance of using a transcultural approach to nutrition therapy with the goal of providing culturally congruent nutrition counseling was identified as being a really important point. The role of various dietary patterns and individual differences like Ramadan and fasting have to be considered. Now, the nutrition checklist. When you see a slide, any of these subsequent slides where it's in red, I've highlighted in red those that are indeed not evidence-based. Refer nutrition counseling by a registered. No, they have no data that shows it has to be a registered dietitian. Follow the Eating Well with Canada food guide. No, that guide, I'll come and show you again, that guide says don't eat fat, don't eat, and that's contrary to what we're finding now. The individual dietary advice is based on preferences and treatment goals. They say, listen, don't try to have your patient do something they don't really like to do. No, that's giving them an excuse. I don't deny that you can't force somebody who doesn't want to do something, but to tell a patient, oh, you just go over and eat whatever you want, and rather than saying, listen, could you cut out your Coke? Could you cut out nutritional or use dairy diet drinks rather than Coca-Cola? Could you stop eating Kellogg's cereal every morning? Could you have an egg and bacon in the morning? These sort of things. That choosing low glycemic index carbohydrate food sources is a documented benefit, and there's good evidence for that. Now, within the guidelines, it says choose healthy fat. What the hell's a healthy fat? Choose healthy fats and avoid trans fatty acids. That is probably true as far as avoiding trans fatty acids. Saturated fatty acids should be reduced to less than 9% of energy intake. I've just quoted you, and I'll quote you some more later. Multiple studies that show that this is not a valid question. Let me point out why it is. If you reduce saturated fats, you reduce LDL. But you do not raise LDL, you also reduce HDL. And HDL is what saves you from heart attacks. And if you go to that approach, you don't actually reduce myocardial infarction. You reduce the LDL content. But it isn't the total LDL, it's the small dense LDL that we have to reduce. And that is not reduced by reducing saturated fat intake. It says choose healthy carbohydrates. I put in, or avoid carbohydrates if you can. That's really better. Dietary fiber, no question, that does help you to delay the absorption of carbohydrate. And so that is a valid statement. Food-based. They advocate eating beans, peas, chickpeas, lentils. These are foods that are really quite foreign to our normal behavior. They're not foreign to South Americans. They're not abnormal for multiple. But to increase whole grains, eat lots of oat, eat lots of bread, I don't understand that. There's no real evidence. And increase fruits and vegetables. Vegetables, fine. Vegetables are good. There's no question that they have a low carbohydrate content and low fat content. But to say eat tons of fruits, boy, if you're a diabetic, you eat tons of fruits, you've got a problem. Choose low glycemic index carbohydrates, fine. If you have to choose a carbohydrate, choose a low glycemic index. To make a low glycemic index valid, you have to teach that patient the difference between a low glycemic, a high or medium, and a high glycemic index food. I promise you, the patients that I've been treating, not for just First Nation, I'm talking about the average patient, does not understand the difference. For example, that if you eat an all-bran cereal, it's okay, but if you eat bran flakes, oh no, that's really bad. There's multiple choices. So the following of Toronto's low glycemic index is a difficult problem. For people with BMI greater than 25, a nutritionally balanced, calorie-reduced diet should be followed to achieve and maintain a lower, healthier body weight. That is a valid recommendation, with the exception of this phrase, nutritionally balanced, because if you reduce carbohydrates and increase fat more than they believe, it also works. A weight loss of 5 to 10% of your total body weight improves insulin sensitivity, glycemic control, blood pressure control, and lipid control. Don't underestimate the value of that. The reduction of this sort of weight is better than any effectiveness, better than any of the medication we have to treat diabetes. And a lot of patients object to taking pills or injections. Stage-targeted strategies for type 2 diabetes. There's no mention in this entire slide of fat intake. And what I'm advocating here is that when you eat some fats, you reduce the desire to eat again. If I have for breakfast scrambled eggs, bacon, and a drink, coffee, I am not hungry. Frankly, it's amazing. I can always go past lunch without thinking about it. Around 3 or 4 o'clock, I get hungry. If I have my usual breakfast of a Kellogg cereal, by 11:30, I need a snack, or I need a cup of something, or a donut from Tim Hortons, and it's amazing. Yet we say, don't eat fat. Eat fat if you want to avoid the hunger sensations. On the other hand, I don't deny there's twice as many calories, 9 calories per gram versus 4 calories per gram. But that doesn't mean you eat tons of it. The point is, it's not bad to eat. Recommendations 1 and 2, people with diabetes should receive nutritional counseling by a registered dietitian. Oh, that's interesting. The grade B evidence, and to reduce hospitalization rates. There's modestly good evidence for both of those. Nutrition education may be delivered either in small group or a one-on-one setting. That was recognized several years ago. If you have a group of people, don't sit them one by one with the dietitian. The interaction of a group of people discussing diet and what they find hard is helpful for the patients. So we've, in our diabetes centers, we have changed to using group counseling on nutrition. It doesn't mean you don't have some individual. Individuals with diabetes should be encouraged to follow the Eating Well with kind of food guide. No, I don't. That's a grade D consensus. You know what a grade D is? Consensus. That means, that sounds pretty good. Yeah, let's follow the. There's no evidence for it at all. In people who are overweight or obesity with diabetes, a nutritionally balanced, calorie-reduced diet should be followed. That's grade A evidence. Yes, calorie-reduced diet is important. An intensive, healthy behavior intervention program combining dietary modification, increased physical activity, may be used, it says, to achieve weight loss, improve glycemic control, and reduce cardiovascular risk. It probably does, but it's only a may. In adults with diabetes, the micronutrient distribution as a percentage of total energy can range to from 45 to 60% carbohydrate, 15 to 20% protein, and 20 to max 35% fat. The trouble is when you reduce carbohydrate, you've got to replace it with something. So you replace it with protein or fat. And the nutritionists have been bought into the cardiology background, which says, oh my God, fat is bad. There's a whole huge additional expose, which I could go through on identifying the fact that that was a mistake from about 1950, that fat was really bad for a person. It doesn't lead to more heart attacks. It's the type of food. In fact, carbohydrates generate more myocardial infarction and heart attacks than a fat intake does. This is a grade D consensus recommendation. There's no evidence that lower carbohydrate intake is not equally acceptable. They've decided that any augmented fat intake might result in bad as total fat. It might result in a bad cardiac effect. And in fact, the data shows it does not. To reduce cardiovascular disease, adults should avoid trans fats. That's also only a grade D recommendation. Unfortunately, I don't deny that trans fats, their evidence is reasonably good, but there's no great study, grade A, grade B evidence that trans fats are bad. And consume less than 9% of total energy from saturated fats. That's a grade C recommendation. And the reason it's a grade C is that they found that it does make LDL go up. And so maybe we shouldn't do it. But the LDL going up is not what's killing people. It's the small dense LDL that causes that. And the other recommendations are grade D. That is a bunch of guys, which included myself, sitting around giving an opinion. It is not based on evidence. Adults with diabetes should select carbohydrate food sources with a low GI. Yeah, if you can, if you understand what's a low, medium, or high GI, you should do that to optimize control. That's a grade D recommendation. Macronutrient distribution, the macronutrient distribution is interesting. It comes up with 45 to 60% carbohydrate. And that is not the easiest thing to do if you don't understand that that entails an understanding of low glycemic, medium, or high glycemic. The key message is people with diabetes should receive nutritional counseling. Yes, that's true. From a registered, I don't know about that. But from a good dietitian, that's true. Nutrition therapy can reduce A1C by 1 to 2%. This is not recognized, that people really should understand how much that really does affect glycemic levels. And when used with other components of diabetes care, can further improve clinical and metabolic outcomes. Reduced caloric intake to achieve and maintain a healthier body weight should be a treatment goal for people with diabetes. And the macronutrient of distribution is flexible. Remember that, it's flexible. But at the same time, they don't agree. They will never, our diabetes Canada did never allow for a low-carb diet to be accepted. It's not even listed on the things. So the key messages are really at play. Replacing high glycemic index, we did that. For people with diabetes, try to prepare more of your meals at home and use fresh, unprocessed ingredients. Now that's one of the problems. Again, we took First Nation people and said, we're going to send you to a residential school. You're not going to have a dinner with your family or eating with your family. You're going to go to a residential school and do what we... Now, how can those people raise their own children with that as their knowledge background. It's very tough. And the fact that eating is a thing that the whole family should be involved in, and training children on how to eat, is where we are failing. Try to prepare meals and eat together as a family is a good way to model healthy food behaviors to children and teenagers, which could help reduce their risk for becoming overweight or developing diabetes. This is an epidemic problem we are now facing, not just in First Nation people. The key message is, with diabetes and recently diagnosed type 2 diabetes, weight loss is this is the guideline. They do admit weight loss is the most important and effective dietary strategy if you're overweight or obese. A weight loss of 5 to 10% of your body weight may help normalize blood sugar. There are many strategies that can help with weight loss. The best strategy is one that you can persuade the patient to take ownership of and can maintain for a long time. Now let's touch on physical activity. No longer do First Nation people involve themselves in hunting, fishing, picking berries, etc. The hunting and the exercise is going to the IGA store and buying food off a food counter. You hunt or choose your food in a store, and you perhaps supplement this with homegrown garden vegetables and obtain physical activity deliberately, not as a method of staying alive, by whatever means you find compatible with your physical activity. This is the important message that we have to get across. Recent documentation that walking or doing physical activity in groups, that's the important word, in groups, enables continuous behavior and greater success. But do not consider activity as a way to burn calories. It helps by reducing insulin resistance. Brief, repeated, at variable times, short-term effort, 15 minutes, 10 minutes of a brief walk somewhere is just as good as an hour broken up into 4 different times. In other words, if you take 4 15 minutes, it's the same as 1 hour. And we do now know that breaking up of activity, if it's important for you, if it's something, the only way you can do it, that works fine. Well, obtaining group training at community centers, for example, is highly effective and durable. Now, this is the reference for home glucose monitoring of the guidelines. I want to recommend that is an excellent thing. I'm not going to spend time going into the reference for HBGYN. Please look that up. This is very well done. Now, there are 2 factors which I'd like to identify from what we've now learned. No longer do we press for continuous home glucose monitoring of type 2 diabetic patients who have been diabetic for 6 months or a year and are embarking on any therapy that, as long as it's not a hypoglycemic inducing therapy. In other words, if you're going to use a sulfonylurea, and if you're going to use a variant of insulin, frequent and continuous, or more frequent, home glucose monitoring is important. But what is essential is to take a new patient with diabetes and say, okay, I want you to do frequent testing. What is the value you should be before a meal? You have to tell them that. Most patients I've seen, both in First Nation and non, they still don't know what they should be before breakfast, 4 to 7, or before lunch, or what they should be 2 hours after eating, that they should be 5 to 10. They haven't been taught that. And yet the patients do this testing and they don't do any change in behavior as a result. So it's a very difficult issue. And those with the risk of hypoglycemia, it's a different story. We have to then have them monitor, but still not 4 times a day or 7 times a day. For type 2 patients, no. For those on insulin and type 1 patients, that's a totally different story. Lastly, I just want to identify, what does low carbohydrate mean? This is a busy slide, but just to point out how many different definitions there are. For early phase induction of popular diets such as Atkins or Protein Power, the very low is indicated. A low carbohydrate diet is 130 grams, or 26%. 26. Remember, the CDA diet is 45 to 60. A low, moderate carbohydrate diet, 26 to 45%. Upper limit, approximate carbohydrate intake before the epidemic. In other words, before the epidemic of obesity, people were eating far less. You can directly correlate our obesity problem in North America by recent changes where the average carbohydrate content is what's gone up. Actual fat content has gone down since 1970, when the obesity epidemic has been occurring. In 1971 to 74, 42% of men had approximate 250 gram out of a 4,050 kilocalorie diet. And by 2000, that had gone up to 49%. And women, the same thing, from 45 to 52%. So a daily carbohydrate restriction maybe should be the first type of evidence. We have on the time frame. Still okay? The dietary component I'd like to address. Hyperglycemia is the most salient feature of diabetes carbohydrate restriction, and that carbohydrate restriction has the greatest effect on decreasing glucose levels. During epidemics of obesity and type 2 diabetes, caloric increases have been due almost entirely to carbohydrate. It's not that we're eating too much McDonald's or too much fat. It's that we're eating too much carbohydrates. The first N. Haynes in 74 to the last, dietary carbohydrate rose, as I said before, from 42 to 49%. The benefits of carbohydrate restriction do not require weight loss because it allows you to not need insulin as much. You do need the insulin for the carbohydrate. You don't need it for the fat. At the same time, no dietary intervention is better than carbohydrate restriction for weight loss. Adherence to a low-carbohydrate diet in people with type 2 diabetes is at least as good as any other dietary intervention and is frequently significantly better. And this the Diabetes Canada admits to, but they don't want to see people restricting carbohydrate, and I don't understand that. Replacement of carbohydrate with protein is generally beneficial, and dietary total and saturated fat do not correlate with the risk for cardiovascular disease, which is the main reason the Diabetes Canada Nutrition Group said we shouldn't increase fat and decrease carbohydrate because you end up increasing fat and you're going to have a risk for cardiac disease. Well, the Pure studies and multiple other ones are showing now that isn't the case. Plasma-saturated fatty acids are controlled not by saturated fat that you intake, but by dietary carbohydrates, much more than dietary fat. And people don't realize that. So we're advocating they eat something that doesn't make any difference. But there's no question that dietary carbohydrates turn to triglycerides. They have to be stored somewhere, so they become fat, and in effect you add to atherosclerosis. The best predictor of microvascular and to a lesser extent macrovascular complications in type 2 diabetes is glycemic control. Dietary carbohydrate restriction is the most effective method other than starvation, which is, as I said from those two studies, the best of reducing triglycerides and increasing HDL. Patients with type 2 diabetes on carbohydrate-restricted diets reduce and frequently eliminate their medication because their sugars go down. People with type 1 diabetes usually require less insulin with reduced carbohydrate. Yes. Intensive glucose lowering by carbohydrate restriction has no side effects comparable to the effects of intensive pharmacological treatment. Just think of that. We've been advocating without helping people with dietary and weight reduction adequately. We've been giving them medication, and those medications do have side effects. 5 to 7% of people with metformin will have diarrhea. That's a serious problem. And people who are getting insulin, hypoglycemic reaction is not fun. It can ruin your whole day. It's like an atom bomb. Home monitoring of blood glucose, of great importance for all, but particularly for the new diabetic. Why? A new patient must learn what foods cause elevations and to what level. So if they've done something wrong, they've eaten a rich fat, what did it do to my blood sugar? Have them test and find that out. They have to learn what their goal levels are before meals and 2 hours after meals. They have to understand what happens when meds are forgotten. Oh my God, I forgot to take my glyburide this morning. What's that going to do? You have to test out to see that. They must see how physical activity makes either an acute or a chronic difference. Physical activity, burning it off, does do an acute difference, but the chronic difference is what's important. And they have to learn, oh my God, if I've done my exercise, walked for 150 minutes a week, or done similar type exercise, I really have reduced my A1C. Has to learn what a true hypoglycemia. We have instances of people on no medication who have been taught about hypoglycemic reactions. Oh yeah, I get hypoglycemic reactions all the time. They don't know that they're not hypoglycemic. They are symptoms of the symptoms like that, but their blood sugar is not below 3.8. So what's going on? They have to learn that a true hypoglycemia. I have many people who say, oh, on metformin I've had more hypoglycemic reactions. But metformin doesn't cause hypoglycemic reactions. It does in addition if you're giving glyburide or some SU or giving insulin, that metformin does make that more frequent. They have to learn when a true reaction occurs and the glucose level should be less than 3.8. Remember, metformin, thiazolidinediones, DPP-4s, SGLT2s, and GLP-1s do not cause, by themselves, hypoglycemia, whereas a sulfonylurea, an alpha-glucosidase inhibitor, and meglitinides and insulin, they do. If you've got a patient on that, you have to be much more careful. So see the Diabetes Canada website for glucose monitoring options. Important to note that provincial pharmacare regulations are variable in what they recommend or will cover. Do you know that the reason we in British Columbia are not able to have DPP-4s without special authority, or any SGLT2s, or even glargine insulin without special favoritism, special allowance, is because they haven't the money to pay for it, the healthcare system. So they said, if you cut down the number of blood glucose tests that you're telling the patient to do, we'll have then the money to pay for these medications. So the result of asking people to test more frequently than is necessary has resulted in us not having available our wonderful new medicines because they're so damn costly. They don't like frequent testing for that reason. If you're not on insulin or an SU, restrict the frequency of testing. Now, there are two things, these continuous monitoring, I'd just like to touch on that. They are really marvelous. They have two types now. There's the Diacom CGM. Many of you know that. That's a continuous glucose monitor that tells you readouts constantly. That's very accurate, and it's very good. But it requires an inborn sampler, and it's a very costly thing. Fine, if the government is going to pay for it, that's wonderful. The Abbott Libre one is an interesting one. You just apply it on and you can just slap your meter anytime over what you've put on your arm. And it gives you an instant readout as many times a day as you want of what your blood sugar is. And that's really marvelous. It's $89 every 2 weeks. That's lethal. So one of the things that the company doesn't advocate, which I think we are advocating, is saying, listen, use the Libre on a new diabetic, put it on for 2 weeks, test frequently, learn what happens when you eat bad food, or learn what happens when you do exercise. And then don't wear it all the time. And 2 months later, you've changed your behavior, and you've changed your diet, your medication. Buy another one for another 2 weeks, and see how you're doing. That is a really beautiful way of doing it. So these things are costly, and but effective. But some may be used only intermittently, as I've just advocated, when adjustments in therapy are being made. And they can then be very valuable. The LifeScan Vario also gives recommendations for how to take measures, what advice on what to do. A1C targets. The A1C target is variable. It is no longer everybody 7%. If you're 85 years of age, do you really need to have an A1C at 6.5 or 7? The A1C at below 7 is to prevent long-term complications. How many people 85 are going to live another 20 years? It's not appropriate. Persons, on the other hand, who's a 23-year-old obese diabetic, that's when we really need to have frequent A1C target reduction. And in those patients, a reduction down to less than 6.5 is actually valid. Most patients is less than 7, and 7.1 to 8.5 is for those who are functionally dependent, have recurrent hypoglycemia, reduced life expectancy, and frail elderly with dementia. Avoid higher A1C to minimize the risk of symptomatic hyperglycemia. By the time you get over a 10, you've got a problem. You get symptomatic. Even though patients swear, oh, it doesn't matter. I'm fine when my blood sugar is 14. But they don't realize they are not well. They are mentally not as competent. And end-of-life factors play a role. So these have been identified for the new adult type 2 diabetic in middle age or lower. Consider an A1C less than 6.5 to reduce long-term risk of cardiovascular disease as well as retinopathy, renal decline, and neuropathy. Cardiovascular trials have shown that if you've already got atherosclerosis, a low glycemic control will probably not prevent you from having cardiovascular disease. Remember, all of our recent trials, from advanced to any of them, none of the trials started with people who don't have any cardiovascular disease. We started with the stack loaded against us in these trials. And therefore, they didn't show that reduction prevents cardiovascular disease. But they already had it, so it's not surprising. None of the trials have used, none of them used only a DPP-4, SGLT2, or GLP-1 agents. All of these trials were using glycoside. The advanced trial was glycoside. The ADOPT trial, all of them were using either insulin or an SU, which produced hypoglycemia. And guess what? When we gave them more hypoglycemic reactions, they had more cardiovascular disease. So it didn't turn out to prevent it. On the other hand, we do need trials now that look at people who are young and can get their A1C down to less than 6.5. Does that prevent disease? We don't know yet, and so it's a difficult problem, but it's very possible. Lastly, I just want to emphasize the correlation between A1C and estimated glucose. I've put that slide in available to you to let you use that as a trial. Right now, we are going to be changing our approaches. Fasting glucose and 2-RPC glucose determinations by lab tests by physicians is not indicated as a guide to your continuing care of your patient. And A1C is clearly now the way to go. And the arguments are terrific because an A1C encompasses a PC sugar as well as an AC sugar. And it encompasses other total variation over a lot of time. But learn that what is an A1C at, for example, 7, its estimated mean glucose is 8.6 to 9.3, and we know that now. Glycemic targets should be individualized, grade 1. In most people with type 2 diabetes, an A1C of less than 7 should be targeted to reduce the risk of microvascular disease. An A1C is grade A level. In people with type 2 diabetes, an A1C less than 6.5 may be targeted to reduce the risk of cardiovascular kidney disease, chronic kidney disease, and retinopathy. Therefore, the new guidelines incorporate that concept. I think we'll take a break now. Is that okay?
Great. Thank you very much, Dr. Dawson, for your very informative presentation, and also for making the connection between the results of current research and application at the point of care for us. We are going to take a break. I see we have a couple of minutes here, so I'm going to use my privilege as moderator just to ask you to expand on a portion of your presentation this morning. You connected the guidelines with the category of research evidence, and I have to say, even after being a healthcare provider for several decades, that I find the category of research evidence still trying to understand how that
The grading of it?
Yeah, the grading of it, and how I should incorporate that into my clinical practice. I find that still a bit challenging to understand. So, but in addition to the clinical trials that you touched on, where do you think research on type 2 diabetes should be focused? And are there research projects going on right now that are focused on those areas?
Well, this is to me the most important point, as I've highlighted or tried to highlight. I personally believe that we've got research trials that are one that's a grade A trial is one that has a control group and a statistically significant outcome by statistics. In other words, the chance is less than 1 or 2% that the finding is false. That's quite different than observational research. We have done so many trials. Do you know how much it costs to run a full research trial for a new drug? It's $50 million. It's vast amounts of money. So we've stopped doing as many of them, and some will never be done to get a true research-based evidence grade A. We have now gone to observation trials. Now, the PURE study is in effect an observation. Just take 140,000 people worldwide and measure find out what they took, and are they better than one group or better than another group, depending on what they took or what lifestyle change they made. And that was done. That is an observational trial. It is suggestive and can be it may be very true, but it's just suggestive evidence. It doesn't pan out that that's always the case. So we have now medication. I'll come to medications in the next session. We have medications now that are absolutely fantastic. What's the problem? Should we do more research on them? No. What we're finding is that patients are not necessarily doing what we think they're doing. The most startling, 49% of people who have a chronic disease are not taking the medicine after 2 years. That's half of your patients. Let me give you a clinical example. A person comes into our mobile clinic and says, what are you on? We have a list whether I'm on metformin and glyburide. Okay, good. And what's your A1C? Well, it was 7.8, but it's gone up to 8.6. Oh, okay. I have to add more medicine, right? We're not winning. We forget to ask, are you taking the medicine? Oh, I've been given it, but I'm not taking it. And we never ask the patient. And what we use in our province is the PharmaNet. We are allowed to, as a physician, to call all the PharmaNet and say, has this patient ever filled the prescription in the last year? Oh, no, they haven't fulfilled it. Well, then you approach that patient quite differently. You don't add another medication. You say, how can we help you? It's really quite important to take the medicine. What's your reason for not taking it? And what could we do to help you remember to take it? Do we put the medicines with your toothbrush or with your breakfast? What can we do? What would you do if you wanted your child to do something? We've got to work with them that way. So I believe the best research is on motivational behavior and getting people to help. Now, the last thing I have to identify is that the problem is cost. And when we have a government system, as we do in Canada as opposed to the U.S., when we have a government system that's paying, I'll go to it later, but these are expensive medicines, some of the new ones. Glyburide is 15 cents a pill. Oh my gosh. I can take 4 metformin a day at a cost of 50 cents or 60 cents. If I take one GLP-1 injection, it's $60. Oh my God. How can the government afford that? I don't deny that there's a real problem. So, but we have marvelous medicines. We have to figure out how to, regulation-wise, get governments to support them, and how we as the healthcare deliverers can help them to produce and support medication. As the First Nation group in Vancouver, in British Columbia, has converted entirely to FNHA, First Nation Health Authority. They used to be under the NIH system, which is you get all these medicines if you're a First Nation person, as you have in Saskatchewan. But the First Nation Health Authority in British Columbia said, oh, we're not going to be disenfranchised. We want everything as good as all the other population, just as good. So they said, okay, the First Nation Health Authority agreed with the government to fund the medicines that are just as well funded but for BC non-First Nation. That now means we can't use glycoside, we can't use the DPP-4, we can't use the SGT, because the First Nation people on NAHB were paid for that, but they've gone to the BC one, and they're not paying for it. So we can't use it. So these restrictions are severe. We need to figure out how to persuade government, and that's why I say have sympathy for the government. Reduce the cost of blood sugar testing that's not profitable. Reduce their costs so that they will give us something, and then hope that in the next 5 years or so, the cost will go down. But meanwhile, get our patients to give them help to follow lifestyle changes.
Thank you very much, Dr. Dawson, for that clarification. And for sure, we'll later on in the day, we'll be hearing more about strategies for funding as well. We're going to take a 15-minute break now. Our broadcast will resume at precisely 10:30 with the continuation of Dr. Dawson's presentation. Enjoy your break. Welcome back. I hope you had a good break. I just wanted to share with you before we start that I'm very pleased to tell you about the healthcare providers that are attending the session today. We have physicians, nurse practitioners, we have registered nurses with the advanced authorized practice category. We have students today as well, nursing and nutrition students. We have dietitians, registered nurses, registered psychiatric nurses, and licensed practical nurses. So a very good cross-section of healthcare providers in the province who would be working with people who need assistance managing their diabetes. Please remember to text in your questions for our question and answer period at the end of Dr. Dawson's session. Again, the text number will be on your screen, and we'll also have our studio audience involved with that. Dr. Dawson is now going to continue his presentation on diabetes care in Indigenous people. Dr. Dawson?
Well, thanks again, and hope you had a nice break. We've been dealing with lifestyle changes that I think is the greatest deficiency. We're not succeeding as healthcare deliverers as well as we could, and it'll make a huge difference. So we've discussed dietary things, but there's in the assessment of a new patient, I'd like to give you a couple tips that perhaps may be of benefit. After you take a history of do a history, you have to make a determination of some sort of a physical exam, whether you're a doctor, a family doctor, a specialist, or a nurse practitioner. And the degree of physical examination has changed in the last 15, 20 years. It's quite important. In our mobile clinic, for example, we have determined physical findings as follows. This is done, again, in our mobile clinic by a nurse, not by a doctor, but it's the same overall thing. We have learned that our nurses do such a superb job that, unfortunately, they make a medical physician not a necessity. Maybe when you get into medication therapy, it's a different story. So we asked that on determining physical findings, the blood pressure seated after a rest. This is one of the most infamous tests I think we have in medicine. It is so unreproducible. You can take, I myself had an exam and I was, the doctor said, I'm 180 over 100. Oh, really? And then I went down, 2 minutes later I was 140 over 75. Now what's the right blood pressure? So you have to do a person after 5 minutes rest. The white coat hypertension or the stress or the exertion makes a big role, plays a big role. But take the blood pressure after a 5-minute rest, preferably taken at least twice. The next physical examination that's important to do, we do have to know something about weight and BMI. BMI, I don't deny, for those who are well-schooled, know that body mass index is being assaulted because a big football player of the Saskatchewan Roughriders would have a BMI that's high, but he could be in extraordinarily good shape. So a body mass index does not always indicate whether a person has excess lipid or excess fat. However, it's an important measure that is important. And we have to remember that a normal BMI is less than 25. Now, we're talking about normal North Americans. The normal BMI for somebody from Asia is 22. And we don't really realize that. We look at all these indices. You have to understand that there are ethnic differences in normal value. But for our North American standards, a body mass index less than 25 is normal, greater than 25 but less than 30 is overweight. Greater than 30 is obese, and a BMI greater than 40 is severe obesity. There's another term, which is what the original one was, which is disparaging, which is morbid obesity. Yet it has validity for the healthcare person. It has bad implications for the patient. If I tell a patient, you're morbidly obese, that means they're about to die. They already think when they've been told they have diabetes, they're about to die. And on top of that, you tell them they're morbidly obese. They have to be told there is severe obesity, on the other hand. So greater than 40. And just as an indication, do you know that of our patients, the average in North America, white population, is about a BMI. When we see them for diabetes, they've been diagnosed, the average is about a BMI of 32. But in our First Nation population, we have 66% of them who are either obese or severely obese. Huge. We have 17% in our studies of First Nation population that are morbidly or severe obesity. That's a huge number. A person 5'3" and 300 pounds. It's a really serious problem. So severe obesity, and it makes a big difference because therapy of a person like that is different. You've got to have a real understanding of where they come. You can't tell a person, oh my God, your BMI is 45 and you should be 25 is normal, so we want you down from 45 to 25. Forget it. That'll never happen. And it's not necessary even to happen. The third thing that on an examination we do is a vibration or light touch pain sensation of the feet. Very easy to do with either a tuning fork or whatever you want to use for a light touch. And then determination of pedal pulses, foot pulses. That's important because these people who are going to be off in the woods or tramping and hunting, for example, and not have foot care and have neuropathy, they're going to be in trouble. To just identify them, any nurse, any person can readily do that. Additional Additional therapy directed to the reduction of cardiovascular events is our next subject. I just want to touch on that. The lab studies to be obtained have been recommended as being a fasting blood glucose or a random glucose, either one, or the A1C and an A1C. Now, the difference is that to have and the same applies for a lipid profile, which I'm going to discuss next, it's preferably in the fasting state. Now, we've just learned that we don't need to do that. We don't need to have a person come in the fasting state. A third or so, or 20% of patients, oh, I forgot I took my medicine, or I forgot I ate breakfast, or I forgot and I did something like that. I just had a coffee and a muffin. And you say, well, you can't do your cholesterol, I can't do your hemoglobin A1C, I can't do your blood sugar. No, that's not true. If you do a hemoglobin A1C, you get a very accurate determination of long-term glycemic status, and that's really what you care about. And secondly, you don't need to do a fasting cholesterol. You just need to do a non-HDL cholesterol. Now, the Canadian Lipid Society has adopted this in the last year. It's being adopted by Obesity Canada. It's a new thing. You do not need to insist that your patient is fasting in order to determine their lipid status. The non-HDL cholesterol, which is simply the total cholesterol minus HDL cholesterol, has to be less than 2.6. Your guideline for LDL cholesterol is less than 2.0, but the LDL by itself has to be determined in a fasting state. But the total cholesterol and the HDL, it can be determined in a non-fasting state, and there you can determine it just if you have the total and you have the HDL, which is attractive, and if it's more than 2.6, it's equivalent to having too many LDL particles, too much LDL cholesterol, which is determined to be the characteristic thing for cardiovascular disease. That's the criteria level for non-HDL, less than 2.6, or LDL, at least less than 2 millimoles per liter, that you have to get to prevent cardiovascular disease. So those are the things you have to do. If triglycerides are too high and you feel you can't use, you can use the non-HDL, or you can also use an ApoB. An ApoB is a special test. It is available. Very few people ever order it, but it's available by any recognized laboratory. And the ApoB is a clear indication of the bad type of lipoprotein associated with cardiovascular disease. And the ApoB has to be less than 0.8. Now, if age greater than 40, you should start a statin now, according to the Canadian guidelines. So the question about statin use and lipids, really, if you've had the disease 8 or 10 years, and even if you don't have bad cholesterol, there's good evidence that starting a statin helps. Now, let me just give you another personal bias. I don't believe a statin is to be given just to reduce the cholesterol or LDL or ApoB or non-HDL cholesterol. It's being given because it's an anti-inflammatory effect. And that's how these, I think they work more even than the LDL reduction. So you have to start a statin if the person has had diabetes for a period of time and clearly is above the age of 40. On the other hand, you don't necessarily have to start. The real criteria for starting a statin is an LDL less than 2 or a non-HDL LDL greater than 2 and a non-HDL greater than 2.6. Then you should start a statin, and you should monitor that effect by repeating it 2 to 3 months later. It doesn't have to be a long term. They are rapid effectiveness, the statins, in reducing those factors. Thirdly, so we've added a glucose determination in the form of an A1C, a lipid in the form of a non-HDL cholesterol, and then a random spot urine for microalbumin to creatinine ratio. Now, there's a huge problem here because nephrologists use gross proteinuria as the characteristic for renal disease, nephropathy, and diabetes. Microalbuminuria, micro quantities of albumin, and the microalbumin to creatinine ratio is done to determine very early disease. And it's marvelous. If you have a person who's greater than 30, that's a clear-cut indication that this patient is headed to renal disease. If you have it, the normal, however, is less than 2.8 for females and less than 1 for males. The normal value is tiny amounts of microalbuminuria. So doing that screening test is like saying, you're not headed for trouble yet, but you'd be wise to reduce your cholesterol and reduce your lipids, to do a regular exercise, to follow a diet to reduce your weight, and to take medicines, and frankly, to take an ACE inhibitor or an ARB, angiotensin converting enzyme inhibitor, ACEI, or an ARB, angiotensin receptor blocker. Both those things will stop and cause a reduction in microalbuminuria, which is a forecaster of possible renal disease, and reducing, just even if the person's not hypertensive and the person has microalbuminuria to a significant degree, they should be given an ACE or an ARB or any other hypertensive therapy that reduces blood pressure to a goal of less than 130/80. And a serum creatinine and an EGFR determination, that is a simple measure calculated for the EGFR, a calculation of renal function. As we get older, people after the age of 75 have a decrease in the EGFR. The EGFR is greater than 30. It's a simple test. It's a calculation that does say, oh, you've got an impairment of renal function. And this becomes important. This becomes important in determining what medication you're going to give your patient. So the serum creatinine, EGFR, and then the optional liver function test. I don't care what, ALT, AST. The point of doing a liver function test is those who are surreptitious alcohol heavy ingesters might be picked up by having their liver function test identified. So then you're ready to say, okay, let's start some medication. What do we do about starting medication? The guidelines roughly identify the following. If your A1C is less than 8.5%, remember what a normal A1C is, about 5.3. It's way down. In Canada, it's different than the US in where pre-diabetes is identified. In the US, it's 5.7 to 6.5 A1C. In the US is. In Canada, we've decided it's 6.0 to 6.5. So the A1C becomes a very important factor for identifying overt diabetes. You can identify overt diabetes by a fasting glucose greater than 7, or a 2-hour PC greater than 11.8, or an A1C greater than 6.5. And below 6.5, however, and all the way down to 5, between 5.3 and 6.5, a huge range, you could be in a stage of early or pre-diabetes. But we define pre-diabetes in Canada by greater than 6.0, but less than 6.5. So if there are no acute complications, you can persist in lifestyle and any traditional medicine, whatever. They can keep on going. But you say, look, now we've got a tag on you, and you're above normal, and you are overtly diabetic. You're above 6.5. But we will give you a few months to see what your lifestyle changes can do. And I promise you, tell them in advance, tell the patient, lifestyle changes is better than taking any medicine. It is more effective. So try to do that before we start medication. We probably will have to start medication, but you can do a hell of a lot in the meanwhile. Now let's work together to do that. So 2 to 3 months, but what's wrong with our system is that we don't see them again. The doctors don't call them back in and automatically say, 2 months later or 3 months later, we're going to get that A1C again. And if you still are above 7, you should start therapy of some sort. They have tried their lifestyle. You want to reinforce that lifestyle changes, but you want to help them with the medication at that point. If the A1C is greater than 8.5, we always said before, start metformin. That is the universal, worldwide, agreed upon medication that is the best starting medication than all of us that we have for a type 2 diabetic who is not obviously ketotic prone. So if it's greater than 8.5, we're also changing, saying, well, you know, there's increasing evidence that starting 2 of them together, whether it's a single combined pill or 2 separate types of medicines, say metformin and a sulfonylurea, or metformin and a DPP-4 such as sitagliptin, that doesn't really matter. They all are amazingly close to the same degree of A1C lowering. For example, if you take a person and start them on metformin, they'll be about a 0.7 to 1.0% A1C reduction. So if you have a person at 8.5 and you give them metformin, just the metformin alone won't get them down much more than a 0.7%, from 8.5 to 7.8. So you're not really curing. However, if you put 2 together that work in different fashion, you may get up to 1.5 drop, which is what you'd really like. If they're at 8.5 and you get them down 1.5, you're down at 7, the goal level. Now, the goal level is determined by, it has its origin, for those who are not aware of this, in retinopathy. What is the level where one of the major complications of diabetes is identified? Well, if you have an A1C greater than 7, you do see people with retinopathy. As a general rule, anything less than 7 will not get retinopathy. So we arbitrarily have defined that A1C of 6.5 as being the level for diabetes. But frankly, it is really unimportant, except from an insurance point of view, and except for financial and job point of view. You have to admit that if I tell you you're diabetic, and you tell your employer or you tell your family or whatever, that has an effect on your life. So it has a, but as far as complications and life goes, you as a person, frankly, if you're 6.4, 6.3, or 6.6, frankly, you're just on a spectrum. It's very little different. So anybody who is 6.0, that's in the pre-diabetes range, to 6.5, really should take into cognizance of the fact that basically they are diabetic. The odds are 60 or so, 70%. They will become diabetic. And you can do something at this point in their life. But later on, it becomes very hard when it's a fixed value. So 8.5, you can persist. Begun immediately. If it's greater than 8.5, take at least 1. And if you wish, take 2. Take 2 at one time. And the costs are not necessarily astronomically different. Any medication reduces it by 0.7 to 1%, and slightly effective in some cases than others. But frankly, all the drug companies say, oh, our drug dropped the A1C on average from 8.1 to 7.9. And my drug, this other one, dropped it from 8.1 to 7.8. So my drug is more effective. That's fact. We can't go around it. But understand, who really gives a damn if they're still at 7.8 or 7.9? It's a tiny thing. It's an arbitrary cutoff. That is not the important thing. The important thing is these people still are in an abnormal range, which is going to lead to complications. And therefore, one drug in one individual may have bigger effect than another, and another drug may have bigger effect than that first drug. But both will have an effect, and this is just a matter of bragging rights. So all of the medication do essentially the same thing. The current worldwide agreement is to start medicine of metformin as the first choice. China is unique. China and parts of Germany uniquely initiates with acarbose or alpha-glucosidase inhibitors. They are a insulin-secreting type, short-acting medication. Maybe culturally, maybe ethnically, there is a difference in Chinese, in the metabolism of metformin. We do know that. The Japanese people do not respond to metformin the same way as Westerners do. So there are differences, but basically metformin is the first choice. How often is it given? I was taught in medical school, you give metformin TID. Absolutely waste of time. Why is that bad? Because the studies were discussing the time for the metabolism of that metformin pill. But what really counts is the guy going to, and you, as opposed to taking it twice a day versus TID, breakfast, noon, and supper. But what counts is what the patient's going to do. And we now know that more than 60% of patients who are given a medicine TID only take it BID because they forget lunchtime or they say, oh, I don't really need it. And we do know that if you give us a little bit larger dose, so instead of 500 TID 3 times a day, you give 1,000 twice a day, you're getting equivalent or better bang for the buck. So starting a medication, please don't start metformin at TID unless you've got a patient. Oh my God, every time I take that pill, I get diarrhea and abdominal cramps. That's the 5 to 7% of the population who get that sort of a reaction from metformin. But 95% of the people don't have a problem. So you can give that BID twice a day and get compliance that you have not gotten before. The most effective and maximal dose of metformin is 1,000 milligrams twice a day. You don't need to go to 2,500. We have people, I used to give up to 3,000 a day, and giving it more at bedtime, sometimes a dose at bedtime, was thought to be more effective because it stops glucose production by the liver overnight in the fasting state. That's how metformin works. So it may be a tiny bit better if you give it at midnight. But frankly, if you're giving 1,000 BID, you're at the maximum dose and don't up the dose or even change its frequency. So the most effective maximum dose, as I said, is that. What is the biggest problem? The biggest problem isn't that you've prescribed this medicine or the patient, the big problem, the patient hasn't been taking it. The biggest problem is the physician or patient inertia. The patient is told, okay, we're going to give you this medicine. We're asking you to take 500 twice a day, BID. I want you back in 2 months or 3 months. I want to see what the effect of that is. No, that doesn't happen. The patient really is in charge. Very few physicians make a major point of calling those patients back on a regular basis. They need to, if they're new to the field of diabetes, they need to be seen every 3 months at least. Reinforcement and check on the medication effectiveness. Because if you give 500 BID, you can raise the dose in 3 months to 1,000 BID and get your effectiveness. And that also identifies the patient who, oh gosh, I didn't take them at night. I only take them in the morning. And this happens with a lot of people. So now we've given metformin and we've checked the A1C afterwards. What do you do? Well, you subsequently add meds at or augment the dose at 1 to 2 month intervals. Now we have a different problems on whether the insurance company or the pharmacare or the NHB or the Plan W in British Columbia, what will they fund? If there are restrictions, you may well need to use a glycoside or glyburide. That is, we don't use glimepiride so much here. They use a sulfonylurea as the second dose. The second thing. Why don't we use SUs anymore as first dose? Well, the degree of glucose lowering is roughly the same as between SU and a metformin. But an SU does cause, in 30% of patients, episodically, at some time, hypoglycemic reactions. Metformin doesn't. Therefore, don't choose as first choice a medicine that causes a hypoglycemic rate. It is not, it's a small number at any given time. It isn't every week or so. That's a different story. But they cause hypoglycemic reactions. Now, does glyburide worse? Yes. Glyburide is considerably worse than glycoside or diamicron in frequency of causing hypoglycemic reactions. Glyburide was a lot cheaper than glycoside originally, but glycoside has been genericized now. So now they're very close to the same. Glycoside is a little more expensive than glyburide. Therefore, our government in British Columbia won't let us use glycoside first. We have to have tried glyburide, which we admit causes more hypoglycemia, and we admit shouldn't be given to patients who have renal and kidney impairment. But glycoside doesn't have that problem. But we're forced to do it. So your next addition, though, in general, is an SU based upon cost factors more than anything else. I personally, if I were diabetic and if I were wealthy, I would take metformin and then a DPP-4. I would forget about a medicine that causes hypoglycemia. I would forget about using SU. But I don't deny it's the cheapest second one we can add. At 15 cents or 50 cents a pill, that's nothing compared to the DPP-4s. We're talking about $2 or so. So there's a real difference. If impaired renal function, again, glycoside replaces. Subsequently, if failure or adverse hypoglycemic, you can obtain permission for an alternate agent in BC, or whatever your regulatory affairs and IHB do stay here. The second choice after an SU or sulfonylurea is adding an incretin or a DPP-4. A DPP-4 such as sitagliptin, linagliptin, saxagliptin, allogliptin, these are medicines that have a strange effect. They are only secreted when food gets down to the bottom of the GI tract, but they have a rapid action. And so how that figures out, they do have an effect quite soon, and they reduce principally postprandial glucose rises. Now, let me give you an example. If you have a person on a broad, long-acting insulin, such as Lantus insulin or NPH, NPH is intermediate acting, but a longer-acting one, if you have a person on that and you then give them the DPP-4, the DPP-4 reduces postprandial glycemia more than it does total hyperglycemia. So if you wanted to say, okay, I've got a person on a long-acting insulin, and I want to control their after eating sugar, because it goes jumping up to 13 or 15. What do? Use a DPP-4, or you can use a rapid-acting insulin with each meal. Now, which would you as a patient rather have? One pill taken in the morning, and then maybe twice a day, is up to you. Or would you rather take an insulin injection every time before a meal, or even one time before a meal? Clearly, if you can get the same effect from the oral agent, it would be better. So the third choice, if you have to use an SU second, the third choice is using a DPP-4. If the A1C is less than 8.5%. And then you have to raise the question of renal impairment. If the person has an EGFR, endogenous glucose, EGF, I've blocked on it. If they have an EGF that shows some impairment of renal function, then you have to use linagliptin, which is a DPP-4 that does not act and have an adverse effect depending on kidney infection, until you get kidney affliction, until you get down to an EGFR of less than 30. So the first choice would be sitagliptin or linagliptin, and then the other choice is saxagliptin. So that's and now we've got metformin, SU, a DPP-4, and finally the SGLT2s. These are, the names are empagliflozin, canagliflozin, dapagliflozin, and the new one, ertagliflozin. There are 4 agents which cause you to to pee out sugar. They cause you to excrete glucose. And you think, gosh, that's a symptom of diabetes. What's good about that? It has a very good effect. It has two big effects. First of all, it significantly, and more so than even DPP-4, reduces the A1C, reduces glycemic levels. Secondly, and even more importantly, it causes weight loss. And gosh, remember, 85 to 90% of our patients are obese. So let's use something that causes a weight loss. There are questions that I believe personally are relatively small. The question is, there has been reports in Europe particularly, but it's been documented, even in North America, that the SGLT2s lead to, in some rare cases, increased amputation in peripheral limbs, particularly small toes and foot amputations. But that's not good, but it's a very small, but there's no question there's an unexplained increased incidence of amputation in about 3% in people using an SGLT2. So if you have somebody who has impaired circulation, which is why I asked you to measure circulation in the feet on your physical exam and a test for sensitivity and neuropathy in the feet, if you have that, then maybe you wouldn't use an SGLT2 as first choice. But you have those choices, and they are very effective. Now, and in combination, they are clearly more effective than either one alone. If success is not achieved, there we go, sorry, or regression after initial therapy. In other words, if you've been a good physician or nurse and you have had the person in follow-up and you've got follow-up finding, no, we haven't gotten enough change. We aren't getting to goal levels. First thing is verify that the patient has been taking the medicine. And I don't care if they forget one pill every 2 weeks. I'm talking about, no, I don't take that noonday pill, or I don't take that bedtime pill. I never take. Oh, really? Or I've stopped entirely because I ran out of money. These were costly, doctor, and I haven't got the money. Up to 50% of patients are not taking the prescribed medicine after 2 years. If that's the case, re-emphasize that medication for a chronic disease must be taken permanently. And unless you found you've lost 15 kilograms and your diabetes, quote, has disappeared, that's marvelous if you can do that. But basically, when you have a chronic disease, the tendency is for it to get worse all by itself over time, and you're passing through more and more time, the odds are the patient will need at least the constant dose permanently. Ask the patient what suggestions the patient may have to enhance continuous therapy. Is it the cost factor? Is it just a preference? Is it an adverse effect? I think I get numbness and tingling in my arms whenever I take that pill. And you say, wait a minute, that's not a usual symptom. You have to believe the patient, but take it in account. Maybe try again later. And another thing, for example, if you have GI side effects from metformin, if you go back after 6 months and try it again in small doses, taken with food, it's very often perfectly acceptable. Why that is, I don't know. But it is a known fact that re-exposure in a patient who had an adverse GI effect from metformin, re-exposure is acceptable and it passes. Verify that life efforts, lifestyle, exercise are reasonable, but no one is perfect. And review options based on the individual situation. Questions along this line are also obtain motivational participation. In other words, what can you do you think that could help you to remember to take these meds? Or what could you do to remember to do your exercise rate? Get motivational behavior as part of that query. So the SGLT inhibition drugs, it has a loss of 60 to 80 grams of glucose in the urine every day. That reduces weight, and it also reduces blood pressure to a degree. Do remember that the SGLT2s are really the only med that we have, well, except for the GLP-1s, but the only oral med that we have which has been shown to reduce cardiovascular adverse events. The cardiologists have jumped on this, and they're giving everybody in their practice a diabetic drug, even though they're not diabetic, because they think, oh gosh, the data shows that if you take an SGLT2, you have less cardiac events, less heart failure, less stroke, and less myocardial infarction. However, that is not a justifiable, in my view, determination. While SGLT2 agents are less effective with lower GI, for example, you're not supposed to use an SGLT2 if the EGFR is less than 50. You're supposed to stop it. But in fact, when they have given it to patients who had impaired renal function, the impaired renal function got better. They weren't so effective in lowering blood sugar when the renal function was down, but they had this side effect. They actually had the unexpected effect of improving renal function and protecting against kidney damage. The DPP-4 agents are slightly less effective in glucose reduction, and they do not reduce weight or blood pressure significantly, but they have less potential adverse effect. There's no potential amputations. There's no potential heart failure. So, after which to add now, choice of oral agents, next step. If the BMI is not excessive, that is maybe less than 32, add a DPP-4. If they're greater, the reason why is that if they're greater than 32, you really do want to get weight down. Now, we've got a weight problem that's quite significant. So you would then choose an SGLT2 over the DPP-4. But there's sort of intermediate second choices, SGLT2s and DPP-4s. For the elderly, you must seek to avoid the risk of hypoglycemia. That's a cogent argument for not using insulin if you can avoid it, and any of the sulfonylureas if you can avoid it. If the BMI is high and the EGFR is above 60, the option of adding an SGLT alone becomes choice in order to assist weight loss, though we do risk the extremities amputation, and there have been reports of diabetes ketoacidosis occurring in type 2 diabetics taking an SGLT2. Remember the doses: empagliflozin 10 to 25, canagliflozin 100 to 300, DAPA 5 to 10, and selaglutide is not out yet, so that it's just out, and we haven't used it yet. What's interesting is that these medicines can now be combined, not just as separate pills, but in combination. So if you're taking, for example, empagliflozin, you can get Synjardy, which, as proved in Canada, they are more costly. But you can get pre-compound tablets. You can get a metformin and an empagliflozin. You can get Invocamet, that is canagliflozin or Invocana, with metformin. Those are single pills, and compliance is a really big factor. So yes, they do go up in cost, but it's the same thing if you go up in cost with a single pill separate or put in one pill together. So you have really 4 choices of SGLT2 medicines and about 4 choices of the DPP-4s. Now, this is a complicated slide. This is adapted from Alice Cheng. She wrote this from Toronto. She's the lead author in the Canadian guidelines, the 2016 edition, and identifies each of the actions. You can see that in the top left, you have acarbose, below that DPP-4, and an outline of small differences that you can expect regarding A1C lowering, risk of hypoglycemia, weight reduction, cardiac outcome benefits, or other considerations such as congestive heart failure, edema. You notice that we have thiazolidinedione still in that list, the 4th one down, but they've essentially slipped off the mark. They really were quite good medicines, but they did 2 things badly. They did increase weight, and they did result in increased incidence of congestive heart failure. So we have to admit that those are not maybe the best, but don't put them aside completely because they are effective. Then we have the GLP-1 receptor agonists, and we have insulin and sulfonylurea. This table does help you if you can retain that table as a guideline. So making decisions after metformin, you think about the clinical situation. What is the patient before you got? Not just every patient the same. Does the patient have cardiovascular disease? If they have cardiovascular disease, I would try to avoid any SU, and I would try to avoid insulin unless necessary. Choose a SGLT2 and even choose a GLP-1. GLP-1 is an incretin that it basically is injected. And they have injected once a day, twice a day, once a week, and now they have it even coming out in pill form. Semaglutide comes out in a pill form. These new drugs are expensive and effective. Frankly, the newest therapy that is the most effective is the combination of insulin with a GLP-1 injection. These are dramatically effective. You can give the GLP-1 even as a once-a-week injection and get a whole week of it. But we're up to $200 an injection. But I don't deny that. But be aware that for high glucose levels, if the A1C is 7 to 8.5, consider the DPP-4. Above 8.5, consider the SGLT2 as the first choice. Is the patient at greater risk for a hypoglycemic episode? Well, then don't use either insulin or sulfonylureas. Use DPP-4 or SGLT2. Is weight management a real priority? Weight management is important for all of them, almost certainly. But if it's a priority, certainly don't use a TZD. Don't use SU, and try to avoid insulin. Is renal function in your patient normal or impaired? Glyburide is no good because it's renally excreted, as opposed to glycoside, which is deactivated in the liver. So if you're using an SU in a patient who has renal function abnormalities, you have to use caution with glyburide and use glycoside. And similarly, there's a caution with saxagliptin, the DPP-4 saxagliptin, which has been found to have an adverse effect in some people with renal disease. And you have to reduce the dose with sitagliptin. And SGLT2s also either reduce the dose or, frankly, the law says, the regulation says, it's not indicated if somebody has an impaired renal function above 40. Is cardiovascular risk present, or are there multiple risk factors? Consider cardiovascular outcomes in their choice. How will the patient pay for medication is the final thing, and that is the biggest problem. SUs are dirt cheap. Metformin is dirt cheap. A DPP-4 is intermediate. A basal insulin is, depending on what one you use, Lantus is more expensive than Basaglar, which is the new Lantus type drug that's out now. And that in my province, we are not allowed to use Lantus. We have to prescribe Basaglar. It is a Lantus type insulin, very similar in its actions. A TZD, if they have to pay, may be a consideration. SGLT2 and GLP-1. Those are written there in ascending order of cost. So SU is cheaper than a DPP-4, cheaper than basal, cheaper than a TZD, than a SGLT2 or GLP-1 agonist. So these are factors that you do have to take into consideration. So let's just spend a little more time on the new boy on the team, the GLP receptor agonist. Let's look at the cost. Is a GLP-1, which has a Canadian dollar value, $41 for therapy, to $62, depending on which one you choose. Is that the cost of the week at a pharmacy? Is that worth its superior A1C lowering, its cardiovascular benefit, and its weight loss? Those values are really true versus a $20 thiazolidinedione or other agent that has less a cost. Frankly, this is a difficult problem for each person, and it depends. But many of our First Nation patients do have employment and have insurance under employment benefits and are more covered than the others are. Is a GLP-1 beneficial as effective an inducer of weight loss and glycemia reduction? The options are liraglutide or Victoza at 1.2 or 1.8 milligrams per day by injection, semaglutide, for those who follow CNN, semaglutide or Ozempic is on the advertising constantly, the new baby on the team. Trulicity, these are all available in Canada. Many of you, I'm sure, are not even aware of them. Dulaglutide, very effective, Lilly. Tanzium has been pulled from the market, so I have to withdraw that. I didn't cross it. It has been withdrawn in this last summer because they just don't want to bother. There's better agents than Tanzium, and they just didn't want to pursue it. And there's Bidurion or exenatide, given once a day or a long-acting form. So you have a choice, and they are clearly as effective weight loss inducers and glycemic reductions, but they are usually, other than the new semaglutide pill, which is coming out next year, they are all by injections. Now, patients initially object to an injection, but once they find how a tiny thing like that is so painless relatively, and secondly, if it's a drug that's only taken once a week, my God, once a week, that's not quite so bad at all. Is adding a basal insulin, which can have the risk of hypoglycemia and weight gain, is it worth the improved A1C efficacy? As different patients have different values and decisions, choosing a treatment regimen should be a shared exercise between the patient and provider. They don't have the information that we've just given you that you have. So you have to try to explain it in lay terms. Yes, it's slightly better, and it's worth it if you want to. How much is your dollar worth? Or do you have a program that covers it? Or are you ready to pay that because you've tried the other and it's hard, it's not as good. I'm not getting the result, and I am really frustrated. I'm trying to do it. Adding a GLP-1 receptor thereafter. If additional control is needed, get a consultation or consider adding a GLP-1 receptor agonist injection after you've done the other 3 orals. Check on such websites as Live Well with Diabetes that discusses each of these variables in layman's terms. And there are 8 head-to-head phase 3 clinical programs that have evaluated the safety and efficacy of the GLP-1 receptor agonists in active comparison. And they include exenatide, given twice weekly, exenatide given once a week only, liraglutide given daily, albiglutide has been withdrawn, that's the one that's withdrawn, and lixisenatide and dulaglutide. So there's a whole bunch out there. They're slightly different in costs, and they're costly, but they are very effective. So we have a lot to offer. GLP-1 injections provide pharmacological levels of GLP-1. This is different. When you take a GLP-1, you're not just getting the tiny amount that's in the normal circulation. You're getting a pharmacological effect of them. And one of the pharmacological effects is that it reduces appetite. And one of the pharmacological effects, unfortunately, is in starting them off, you get nausea and vomiting in a significant number of people. They have to learn to say, I can accept a small amount of nausea for the benefit, and it passes off usually in 2 to 4 weeks. But that's something you have to discuss with the patient. It reduces glucose and weight by increasing glucose-dependent insulin secretion. In other words, if the sugar is low and you give a GLP-1, it doesn't cause insulin secretion. It's only if the sugar is high. So you're sort of protected, you are protected against that effect of a GLP-1 in causing hypoglycemia. If the sugar is high, it reduces the sugar. It reduces appetite, decreases glucagon secretion. Glucagon, remember, is the hormone that's secreted by the liver that you give to a patient, for example, a type 1 patient, who you've given insulin to, and there they are with a hypoglycemic reaction, or a convulsion even. You give glucagon. Well, this agent decreases glucagon secretion from the liver. Therefore, it decreases the hormone, the natural hormone. It decreases the effect of it on reducing, on glucose lowering, and starts you to stimulate glucose production from the liver to counteract a hypoglycemic reaction. And it does delay gastric emptying and increases satiety. That's at the pharmacological level. In the normal level, it doesn't matter. But when we give it this way as an injection, we also get the benefit of satiety. They eat a small meal and they're happy. They don't need more. It delays gastric emptying. Most common effects, adverse effects of the GLP-1 RA class are the GI-related nausea, vomiting, and diarrhea. And sometimes there's injection site reactions, but that occurs almost with anything. Currently, there are 4 receptor agonists approved for use in the United States, and Canada. So we have Trulicity, dulaglutide. What is that per week? That's $52 a week. Remember, if you're taking 1 or 2 glyburide a day, that's 30 cents a day for 7 days, $2.10 a week. This drug is $52 a week. Exenatide Byetta, 36. Victoza or liraglutide, $41.77 for a week. And for the higher dose, $62 per week. Ozempic, the semaglutide, and the data for that is very surprisingly good. $225 for 1.5 ml pen, which can be used for several days. This is expensive stuff. GLP receptor agonists, liraglutide, Trulicity, and we've crossed off Esperanza there, and semaglutide are all human-based GLP-1 agonists. Semaglutide is 94% homology to human. In other words, it's a real human-like molecule. Liraglutide has a once-daily dosing. Oh, that's nice, once a day. Dulaglutide and semaglutide are once-weekly injections. Administering these agonists, they've become available only in the last 2 years. Major studies on large groups of patients are not available yet. Cardiovascular benefits are only available for release of the drug. If they've shown that they have not increased cardiovascular events, they've been approved. They have studies to that effect, but combinations and use of these is not extensively studied. In the Duration 1 trial, that's the name of an official large trial, exenatide once weekly significantly lowered fasting glucose when compared with twice daily of another one. The proportion of patients achieving an A1C of less than 7% was 58% and 30% in the weekly and twice weekly. Now, just to hark back a moment, I showed you those 2 recent studies on marked weight reduction by restricting food intake. They were both in the same range as this very expensive new drug, 58% or 60, or it went up to 75% longer term. So we have options that include the lifestyle plus that. Body weight reduction similar was observed in the two studies. Once daily liraglutide versus once weekly exenatide was studied. And basically, it shows that these are similar. One's a little better than another, but they're similar agents, and they, in effect, act fairly similarly. Dulaglutide, once a week, versus liraglutide, another study, once weekly dulaglutide versus daily liraglutide. The mean change in A1C now, you see the change in A, we're up to a negative 1.42. That's a drop from, if you were 8.4, you'd get down to 7. And 1.36 in dulaglutide and liraglutide groups, respectively. Both groups resulted in 68% of patients achieving an A1C of less than 7%. Weight reduction was significantly greater in liraglutide compared to dulaglutide. So there are little differences that may or may not have great validity. The point is, for an added cost, you can get an significantly added benefit. Now, what about this? What if you have a really obese patient who weight is a real priority and hyperglycemia? You can combine a GLP-1 with SGLT2. That's the duration trial. The pill, remember, the SGLT2 causes you to pee out the urine, in your urine, the glucose, and the GLP-1 acts to stop glucagon and stimulates insulin. So at 28-week randomized control trial, the Bydureon GLP-1 receptor of 2 milligrams once weekly added to an SGLT inhibitor, dapagliflozin in this case, taking the full dose, 10 milligrams once daily, from an initial mean A1C of 9.3, A1C improved by 2% with the combination, a 4 percentage point greater than seen with exenatide alone, 0.6% greater than dapagliflozin alone, and exenatide plus DAPA was also significantly better than either one alone for all secondary efficacy endpoints. They provided a 7.5-pound weight loss over baseline, compared with a 1.54 by exenatide. So we're getting into the high importance values, but we're getting into high importance costs. 2.1 kilogram of dapagliflozin alone, and favored the combination. We're now in the era of combination. I have another couple of minutes. When do you have to consider insulin? The first thing at any time, you have to consider insulin at any time, even in newly diagnosed patients. Our use of insulin has changed considerably. Believe me, I come from an era when we used basically insulin in most people with type 2 diabetics all the time. We are now in an era where I personally believe the vast majority, 90%, will not need insulin. Remember that clinical classification that I showed you before. There are certain in the top group that will need it, but we have oral agents now and other injections which work terrifically. Current availability of multiple oral agents has resulted in marked delay or even negation of insulin use in most patients. Insulin use demands some, if not frequent, home glucose monitoring, so we also find that's financially advantageous. What's in favor of the use of insulins? They're very effective, and they can reduce any level of hypoglycemia. You may have to give 150 units of insulin twice a day. You have to go to Toujeo. You have to go to these very potent, combined, concentrated insulins. But it can be very simple or even very complicated. The disadvantages, you must approach the person who needs insulin as you being a helper, as to gain glycemic control rather than as punishment for failure. It requires that a major effort at carbohydrate intake reduction has been attempted before use, and for understanding what a carbohydrate is. You may offer withdrawal in time. We used to say, gosh, if you start insulin, you never can stop it. No, we've now, that used to be because we found that you stop it and then you go back to it, you had an incidence, high incidence of allergic reactions. Well, we find that that's no longer the case with the improved insulins. So you can stop it and you can restart it again. Warn that weight gain often occurs and calorie reduction is essential if one just ends up with otherwise ever increasing doses of insulin and ever increasing weight. In those patients who have insulin resistance, it's astounding. They gain weight, you're giving them more, you're giving prodigious amounts of insulin at high cost, and nothing happens. Nothing good happens. You must educate the patient and the family in hypoglycemic symptoms and therapy. Oh, I've already done that, okay. You can consider other insulin formulations. There's premixed insulin. It is clear that when you get to the point where you've got a basal insulin and gosh, I gotta add a pre-meal. If you start, you can do one pre-meal, but if you start to three pre-meal plus a basal, it is better to go to the old-fashioned 70-30 or Humulin 25. These are fast-acting, rapid-acting insulin combined with long-acting, only given twice a day. That is better than 3 times a day before each meal and long-acting at bedtime. Remember the following. When you start insulin, it is better to start the Lantus type by an injection at bedtime. Why is that? Because there's a simple algorithm for deciding what. You start at 10 units of Lantus at bedtime, and you then go to measuring the fasting sugar. If its average is 9 or 10, you need to increase the dose by 1 to 2. Keep increasing the dose every day until the patient's home monitoring fasting glucose is less than 7. You can do it less than 6 or 5, but certainly less than 7. And that really is very effective in achieving the dose. If you train the patient and you have a reasonably educated patient, or you as a healthcare provider are close enough to be able to review them and their results every week. You can consider oral agents plus insulin. Long-acting insulin at bedtime still results are better than still results in high glucose levels. If they're still high before that, you can add rapid or short-acting before supper. But it's actually effective to add a pill for doing that, DPP-4. So I think we've covered a great deal, and some of the other slides do go into anti-hyperglycemic therapy. But let me go to one last thing that we have to identify. Antihypertensive therapy, the goal is 130/70. Very few doctors are concerned when the patient's 145/85/90. But the data is quite impressive for cardiovascular benefit. The medicines should be probably an ACE inhibitor first. If that fails, or if you have a cough, you use an ARB. If that fails, you go to a calcium channel blocker or a thiazide. The recent evidence is that calcium channel blocker is better than the thiazide. We used to use a thiazide added to an ACE inhibitor beforehand. And we use it for hypertension as well as renal prevention. Continuous support is essential and appreciated. This may vary from initial circles or groups of members who meet to discuss self-management every 1 to 3 weeks. Discuss individual problems of lifestyle. What is your physical activity? Discuss diet and medication adherence and stress factors. My gosh, my daughter's going through a divorce. I can't cope with this. Personal discussions are needed. Allow time to meet in one-on-one. Now, our Visit the Guidelines website, that's available to you here. I would really recommend these incredibly well-constructed websites. Don't pay that. And then finally, we'd like to identify that we have the livewellwithdiabetes.com. And for those in First Nation care, I would urge you to go to www.diabetes in my nation. This is an extensive thing with multiple medication instructions, dietitian instruction, etc., that has been shown and worked with First Nation communities. So with that as your homework, I thank you very much.
Thank you for your informative and thought-provoking presentations on this important topic, Dr. Dawson, and also for helping us make the connections between assessment and treatment options and patient outcomes. Before we start our question period, I just want to remind registered participants that you would have received an email yesterday with a link to access copies of our speakers' presentations. If you have any questions, you can contact CEDN, and that will be familiar to you because you would have gone to the CEDN website to find the registration link for this event. We're going to now take some questions from participants. I'm going to ask our studio audience first if there are any questions, and I would ask you to please step up to a microphone in the studio and introduce yourself and ask your question. Are there any questions at this time from the studio audience? I'm prepared for this. I have questions. I have a text question that came in. Dr. Dawson, I'll start with that. The question was, does sitagliptin cause more cardiovascular events?
Well, no. Saxagliptin was given the bad mark for having a slight increase. I frankly think that these are vast studies that show that it was a 1 to 2% increase, and it's a tiny one. But no, sitagliptin is, in my view, the most one of the most efficacious and acceptable ones. It was withdrawn in my province, believe it or not. We are not allowed to use sitagliptin. Why? Because the company didn't reduce the price enough. So there's no significant objection to sitagliptin in cardiovascular disease.
Okay, thank you. I have, unless anyone's jumping up in the audience, I don't see that. I have some other questions here as well. Dr. Dawson, in an individual whose A1C is 8.2% and whose metabolic state is stable, would you be able to start this individual on another medication other than metformin?
Yes, of course you can. Metformin is the choice because it has a relatively low adverse effect profile. It has a very low cost, and everywhere in the world it seems, except maybe in Japanese, to be effective. So you don't have to start with metformin. All the other ones are all equally effective. They don't have to have got metformin in the background. So if I gave that impression, because we all start with metformin and add the other ones, no, you can start with any one that you want. They all are effective. So if you have a good reason that not wanting to try metformin, you can use a sulfonylurea. You can use a thiazolidine. You can use a DPP-4 or an SGLT2. But those are the ones that are, normally we use all of that array of non-injectable. And of course, you can use insulin.
So in addition to cost, what would be some other considerations to use for using another medication other than metformin as a first-line therapy in individuals whose metabolic state is stable?
Well, so for example, I have personally not concerned. The European Association has said, oh, the SGLT2s cause significant amputations. Well, amputations is pretty bad. That's not a cost item. That's not good. But it's a very, very low incidence. And if you don't have pre-existing likelihood, but I must admit, they did go back and look at those patients, and there was no clear-cut indication that only patients who had pre-existing impaired circulation or impaired neuropathy got the amputation. But certainly they have seen it, and it remains unexplained. Those medications that, for example, produce heart failure at an increased rate. Thiazolidine. I have a personal story. I put the dean of medicine into heart failure by giving myself a thiazolidine ion. I've been burned by that, so I'm not ready to say use of it. I would use metformin as the lowest incidence of side effects. because the GI side effects you get with metformin are not serious things. An amputation is serious. A GI side effect, you're not even sure whether it's something you ate that day. And it does usually disappear. So that's the only thing. And the cost is better. So that really is the reason people have used it as the first choice. It isn't just other factors. You take into account those secondary adverse effects, but they're all low incidence. And cost. Cost is the biggest one.
And that sort of covers the next sort of 3 parts to this question. You've talked about the differences in funding between British Columbia and other provinces. Would NIHB and other insurance carriers cover a prescription other than metformin as a first-line medication?
You know, it's been 2 years since we were under NIHB, and I've honestly forgotten. I would ask that question of our subsequent speakers, but I think they do. I don't think they demand it as a first. I don't know whether you have to give some explanation, but certainly you can use a sulfonylurea as opposed to metformin right off the bat. Whether you can use SGLT2 or something, I don't know the answer. I doubt it.
And you're right.
That's
we will have a presentation
That's
about
right.
that
Shortly.
later on in the day. I'm just going to give a reminder right now to have participants send their text questions in. I'm ready. I'm queued up here to receive your questions. Any questions? Does this generate any questions from the studio audience yet, or? It's probably the camera has frightened you off. That's okay.
I'm surprised how many in the audience feel that they feel more competent to deal or figure they can. And if any of you have real secrets, I would love somebody's advice. My best advice has come from one of our nurses. I won't identify him because for his privacy. Absolutely superb ideas or recommendations based on dealing with First Nation people that we hadn't thought of. And I'd like to ask anyone in the audience who has any tips on what they have found works well and helps us a lot. No volunteers?
We'll let you think about that. I have a few other prepared questions here, but yes, please do jump up if you have something to share.
That's
Dr. Dawson, there are studies that indicate that First Nations people living with diabetes have higher prevalence of chronic kidney disease. Is there any information about long-term use of SGLT2?
No, we haven't gotten long enough for that. And as I mentioned, that's a surprising outcome. We can't use it. So first of all, people who have impairment, as soon as you see there's an impaired function, you're told, oh, you shouldn't use that. But in fact, when they've used them in various other circumstances, studies, they have found that it reduced the renal decline. And how that happens, I have no idea. But there's no long-term studies in the face of that objection, the fact that to get approval, they had to say, don't use in renal decline. So there's no long-term studies of their use in decline patients, renal decline.
I do have a question that's come by text. Dr. Dawson, what EGFR do you suggest substituting and or using or stopping metformin in Indigenous clients?
That's a really good, I know of no difference between Indigenous and non-Indigenous. There's no ethnic that I know of difference in those two groups in Canada. Metformin originally, as everybody know, when we were taught in med school, it was to start as a 3 times a day dose, and it was really dangerous because you got renal acute problem from that. It's been found that isn't the case at all. And a doctor from Alberta has done the biggest study in the world regarding the use of metformin in renally impaired people. And it used to be below 60, oh, be careful. Below 50, oh, maybe you shouldn't. Below 30, stop. In fact, we still have that regulation. But in fact, they haven't found the problem at all frequently. So there's a question even whether any restriction on it, but at least an EGFR less than 30 should be. Before that, above that, you might want to decrease the dose, between 30 and 45, from 2,000 a day to 1,000 a day. But other than that, 30 is the cutoff still. And I even question whether that's a rational thing.
So from what you said, do you foresee metformin not being a first-line treatment in populations that are at high risk for chronic kidney disease?
No, I don't think, the implication of that question is that metformin is causing kidney disease. It's not causing kidney disease. It's just that lactic acidosis may occur. They thought it occurred at a higher frequency. It is only in people, it was found actually the lactic acidosis that occurred were people who also had advanced heart disease as well as kidney disease. And so that may not be a factor. The fact that it is so inexpensive, the only, I think, indication for not starting it is if you have a person who gets an allergy. And by the way, we've had patients, I mentioned this before, we've had many patients who start the drug, oh my gosh, I get diarrhea and abdominal cramps and gas. And okay, fine, stop it, or take it with food first. Make sure your patient is taking it with food. Secondly, reduce the dose, and then build up. And that happens, and pretty soon they're able to. Then there's a hardcore group of people who have an allergy, and it stays with them, or they have a problem. Don't keep trying on those patients. After persistence, if they still have it, give it up, because they will never get rid of it. In those that persist in having it, after taking it less dose, or then building up, or taking it with food and building up. If they still have it, give up. Don't push it. They will never avoid the GI adverse effects.
Okay. Another question came in by text. How come SGLT2, beside the cost, is not used sooner in diabetic patients?
I don't think there is a reason for other than, well, there are people, physicians and patients, who say, oh, wait a minute, you said that drug caused increased amputations. I don't want that. Now, it's 1 in 1,500 or something of people who are also in heart failure. Forget it, chance alone could have done that. So there are people who just avoid it. And if you have a person who is made knowledgeable about the side effects and has been told that you trade off the cardiac benefit for an adverse amputation effect, and I say, I don't want it, then don't do what the patient doesn't want. You can explain that you think it's low, but if they still, you must have their cooperation. Once a patient has decided, in my view, once a patient has decided something is due to this pill, you can't don't bother overcoming it. People really believe what they believe. And we'll try to educate and try to help them, or think of ways to try again. But if that fails, don't do that. Don't do it. They'll never take it. So I would love to make it, if you say other than cost, I do happen to think that DP4 SGLT2 and maybe a GLP-1 injection in the future, that's the way of the future. But right now, it's just the cost factor.
Prohibitive. Yeah. Here's a text message, not a question, but a comment. I work in the area of kidney disease. So many patients believe metformin destroyed their kidneys. Word spreads around and people are scared to take any medications. There's such a high need for better patient education and more timely education in a way they can understand.
There's no question that's true, but there's a timely need for all of us to get educated. You know, as 30 years ago, I was treating patients with metformin, and I'd back off with renal impairment. Oh, no, bad. And then we've studied it more. My gosh, that was a mistake. But if I told a patient, or they heard from their next door neighbor, oh, metformin can cause kidney trouble, there's no way you can get around that. I believe it's false, but you cannot change a person. So if the person really believes that, give him the grace to accept their word. Don't persist in it.
Okay. I'll just check with our studio audience. Yes. If you can step up to the microphone, introduce yourself.
My name is Faye Evans, and I'm a nurse. Thank you very much for all the information that you've provided today, Dr. Dawson. But my question is, would you start a person who has prediabetes on any medication?
Now thank you, Fee, very much for that question, because it's one we deal with all the time. I think it depends upon your patient, and it depends upon your philosophical attitude as a doctor. There's a beautiful study does show that you reduce the progression to overt diabetes by adding metformin. Is it because there is a slight appetite suppression effectiveness? Is that how it works? What is it actually doing? It isn't doing anything other than what you think. But the question is, yes, if you believe you really have a patient, my God, I don't want to ever have diabetes. Okay, I can reduce your risk if you take one pill twice a day. And they say, oh yeah, I'd love it. Then you do it. If you have a person who says, I really hate to take any pills, I think it's a show of a sign of weakness, I don't want to do that, don't give them pills. It's a sign of weakness, right? So lose weight, do exercise, do anything that works just as well as, or even better than starting metformin will. So you've got to deal with the individual patient fee, I think. But that's a good question. And I don't think, as I said to Kathy, I don't believe there's any evidence of causing kidney trouble. It's that it's a good agent. It does help it. The degree of prevention is small. DeFranzo did the study. And the degree of help is rather small, but it does help. So if you got somebody who really wants it, let them do it. It does work. And it makes a person, if you believe in that, if they believe in it, it makes them feel, they feel, I'm doing something, I'm taking charge, I'm doing something on my own to try and prevent this from happening. That's a good idea. But meanwhile, just do tell. I am really utterly convinced that weight is the biggest thing that causes the manifestation of type 2, not the cause of the disease, causes the manifestation of it. You have the genetic predisposition. If you have the metabolic syndrome, 23% of the population has the metabolic syndrome. And where you fit on that whole spectrum is depending on where you are in life at this point. When you get older, you'll get it. And yes, you can take a pill to prevent it, but it has a minimal effectiveness compared to many other things you can do, such as weight reduction and caloric restriction.
I have what I think is one last question, unless there's more questions from the audience. What are some of the promising practices you have experienced in your work with First Nations people living with diabetes in First Nation communities?
I think the most surprising, I shouldn't say this is surprising, but I hate to admit it, I should have known better. The fact that, first of all, the two biggest problems are shared by the First Nation person who has a historical perspective that I didn't realize was so impressive. It's so discouraging. I think, did I give you the story? I had a patient who was sent to the diabetes center, and the diabetes center was at a hospital, it shall remain nameless, St. Paul's Hospital. Sent to the hospital for a diabetes education, and he was very positively, he's a chief, very positively oriented to helping himself. He went and he just looked at that building. He said, that looks just like the residential school that I attended for 10 years that ruined my life. I won't go in that building. Well, I never realized the depth of the adverse effect of that in people's thinking. And that's the biggest thing that I've ever, anecdotal story that I can say. I recognize I also learned from using Pharmanet in the last 3 years. We've got all of our team. We have some 5,000 First Nation people on our program. And using Pharmanet to discover how frequent it was, they couldn't have been taking those medicines. They aren't lying to us, but they don't like to tell you that, oh, I didn't do what you said, Doc. No, they don't want to say that. So they say, oh, yeah, I skip the medicine. I forget the medicine occasionally. Ha! Not occasionally. That's just their method of socially saying something to you that is an adverse thing. And they don't want to say, oh, I never take that. That is surprising how frequently. Do you know that if a person had a myocardial infarction and is discharged from the hospital, this is not a First Nation, all people, and is discharged from the hospital, having just had a heart attack, and the doctor gives him a prescription, 22% of the time the patient never takes that prescription to a drugstore. I just can't understand that. So we have to understand that there's adversity to our healthcare delivery and fear of medication that many of us don't understand. If we've gone through the healthcare system, we've said, oh, most medicines are pretty damn good. We don't have a view of them. It's an important view that we have to take in mind and take into consideration in treating our patients, and treat empathetically and sympathetically.
Thank you very much for your perspectives, and thank you all for your great questions. We're going to take a lunch break now, and our broadcast will resume at precisely 12:40 p.m. I would ask you to be back a couple of minutes before 12:40 so that we can start right on time. Enjoy your lunch.